please feel free to send a direct chat to myself or any of the doctors that are with us. We have Dr. Shaheen, Dr. Stickles, and Dr. Martin with us, just to so you can identify who they are. And I'm going to get started. So my name is Nina, and I am the Senior Wellness Program Manager at Unite for Her. Some of your names I recognize, faces I have seen before at our wellness days, and for the rest of you, welcome. Thank you for joining us for our speaker series on ovarian cancer. With September being Ovarian Cancer Month, we thought it would be a perfect opportunity to host this fantastic panel of physicians to discuss some of the hot topics surrounding ovarian cancer, and then also to help answer any questions you might have about effective or new and upcoming treatments, clinical trials, recurrence concerns, and more. I wanted to begin this evening by welcoming you all, both as a part of the Unite for Her Wellness Program and passport holders, and also to this speaker series specifically. We hope that you're finding the Unite for Her community and the services available through your passport to be your opportunity to create your own treatment plan that you will find to be supportive of your health as you move through your treatments and even beyond those treatments. And as a reminder for our recurrent ovarian women, Unite for Her will renew your passport once every 6 months once you've used all of the squares inside your passport. So you really just have to reach out to myself and we will send you a new one, and then you get to go through your passport of services all over again. We have 3 physicians with us this evening, with our moderator being Dr. Mark Shaheen. Dr. Shaheen is the director of the Hanjani Institute for Gynecologic Oncology at Jefferson Abington Hospital. And we are fortunate enough to also have him as one of our board members and medical advisors for Unite for Her. We also have Dr. Martin from Penn Medicine and Dr. Stickles from Mainline Health with us. And I will allow Dr. Shaheen to introduce them both in just a bit. And then if you want to stick around in the end, I will also touch on just a few of the upcoming Unite for Her events at the end of this event. And we have a couple exciting fundraising events going on, a couple conferences that I would like to make you all aware of. And, I can stick around for any questions that you might have outside of our panel as well. So without further ado, I would like to find Dr. Shaheen and spotlight him. He, again, is our moderator for this evening.
Thank you, Nina.
Hi, Dr. Shaheen.
Can you hear me?
Yes, I can.
All right. It's a really pleasure and honor to be amongst all of you. And it's typically folks like Dr. Stickles and Dr. Martin and I would get together in a normal year and have a meeting in some good location and exchange a lot of scientific information. Due to the current crisis, the best we can do, even when we live in Philadelphia, is to see each other virtually. So I'm actually really honored to have both of them on the list of physicians for this evening and have their expertise imparted to all you folks. This event is for you at the end of the day, and I want to make sure you all walk away with more knowledge and more information. Dr. Lainey Martin is an associate professor of medicine at University of Pennsylvania. She is extremely brilliant. I'm always in awe when she speaks at national meetings and exchanges, her opinion and her comments about the subjects that she's has expertise in. I know she is keenly involved with many clinical trials, including design of some of really early phase trials for drugs in ovarian cancer. She's a medical oncologist, but I think she would identify herself as a medical gynecologic oncologist, and really has dedicated her career to the diseases spectrum of gynecologic cancers. So I'm honored to have her along with us. Dr. Stickles is at Mainline Health. She has been in Philadelphia area for nearly a decade now, I guess. Maybe I'm overestimating. Really a phenomenal gynecologic oncologist. I've met her only once or twice, but I'm always impressed by the care that she has provided to her patients and the appropriate counseling that she has done. And many of her patients speak tremendously highly of the dedication that she has exhibited to them. We come to you as, medical and GYN oncologist community, but a group of physicians that are really dedicated to the care of women with gynecologic cancer. And I think between the three of us, you see a wide spectrum of years of practice. So I wanted to open the evening and talk about the fact that ovarian cancer continues to remain a real challenge for our specialty. And this year, there will be about 25,000 new cases of ovarian cancer diagnosed. And I wanted to give an opportunity to the rest of the physicians to just tell me where do you see the trends? How do you see it from your vantage point? Are things better, worse? Are we doing better with this disease? And do you see any hopes in screening for this cancer at all? So I'll start with Dr. Stickles.
Hi, thank you for that kind introduction, Dr. Shaheen. In terms of where the field is going, I think every couple of years there's, at least in my relatively new career, I've seen there's something very new and exciting. In the beginning of my career was bevacizumab, and I think for the last 5 years or so, it's PARP inhibitors. At any given point, an ovarian cancer patient will be receiving a PARP inhibitor during some course of her treatment. Physicians like Dr. Martin really have spearheaded clinical trials and looking at how we can incorporate these oral medications that have a different toxicity profile, generally more preferable for patients than the traditional chemotherapy we're administering. And it's one of the very exciting new developments in our field in that we're maintaining patients in their remission, both at the time of diagnosis, but also after recurrence. And I think that's one of the most exciting things for me as a physician treating women with ovarian cancer.
Do you recommend any specific screening to your gynecology colleagues as they ask you, an expert in the community you practice? Do you tell them anything differently?
Yeah, I get questions all the time. I do have a fairly large following in patients that have hereditary cancer syndromes or other risk factors that increase your risk for ovarian cancer. So I counsel patients differently based on what we as medical professionals perceive their risk to be. So for patients who have a known genetic predisposition, such as someone who received a BRCA or Lynch syndrome diagnosis because, say, a family member had been diagnosed and they were subsequently diagnosed and they themselves had not had cancer yet, really the goal is prevention. And part of that is trying to determine when is the best time for that patient to undergo risk-reducing surgery. And what we describe as screening, and I tell my patients air quote screening, is that there's mixed data in high risk and also in a general population about the efficacy of screening. For patients, most what they want to know is, if I undergo the screening, is it going to make a difference for me? Is it going to diagnose my cancer at an earlier stage? Am I more likely to survive this cancer? Because ultimately people are afraid of this disease. And there's really not great consistent data in the general population that screening with either ultrasounds or blood tests is really useful. There are a couple of big studies that have been done within the last 10 to 15 years. There's some suggestion that if you follow people long enough, there may be a small benefit in detecting cancers, but a lot of the compounding factors in those studies is that a lot of the cancers that were detected in the screening group were detected at the time of enrollment. So the patient came in, they already had a cancer. It's not necessary that the screening over time really picked up on those cancers. But the higher risk patients, I think the conversation is a little bit easier because ultimately most of them are going to be wanting surgery, and we're using screening with ultrasound, with blood tests more as a tie over, if you will. So when there's a defined endpoint, the way I counsel those patients, like the BRCA patients, the Lynch syndrome patients, is that ultimately we're going to try to get you to surgery at some point. What we do in the interim may make you feel good about yourself that particular day when the ultrasound was normal, the CA-125 blood test was normal, and you feel good. But the disease process is such that we may not be able to screen people frequently enough to prevent them from developing cancer in the first place. The other caveat I discuss with my high-risk patients in particular is that there's a high probability of false positives, mostly because these are young women. They are of reproductive age, and masses on ovaries are fairly frequently seen. And the majority of those, even in the high-risk patients, are not going to be cancer. So there can be a lot of anxiety associated with that. For the patients that do not have a genetic predisposition, so the gynecologist saying, hey, I have a woman that's coming in, she's asking me, she's 55 years old, postmenopausal, she's asking me, how do I prevent ovarian cancer? Can I screen for it? For that person, I'm not recommending screening just because I think the data is really not quite ready yet for prime time. There are some very interesting preclinical studies being done looking at tumor-free DNA, or what people might be calling liquid biopsy. These are small fragments of cancer's genetic material that are free floating in people's bloodstreams that may be able to be detected by a blood test. I think that's very promising. I'm very excited about that, but at the same time, it's not commercially available. It's not necessarily validated for use yet. So I'm not recommending anything from that perspective.
Thank you, Dr. Stickles. Lainey Martin, I saw a patient this morning, actually 51 years of age, and just had a pelvic mass and some new ascites. And she asked me that last year she missed her gynecologic examination, and is that why she now has ovarian cancer? How do you approach that patient? Try to reassure her that it really wasn't her fault, and even because I really sincerely believe that a normal gynecologic examination doesn't necessarily reassure you about absence of ovarian cancer. And do you feel like you see a trend of the disease maybe in younger patients? And just share your thoughts if you could, please.
Yeah, I mean, I agree. Everything Dr. Stickles said is exactly right. And I've had the honor of seeing a few of her patients, and she always gives phenomenal care and great advice. And, there really is not an effective screening for this. And so we really have to operate on women that we think are high risk, and that tension of what's the right timing, to do that, to prevent a cancer, but not do it too early, right? Physical exam, even going so far as to do transvaginal ultrasounds, has really not been proven to identify these cancers at an early curable stage. I think I agree with Dr. Stickles that some sort of blood test is probably going to be the way we screen for a number of cancers. But I think we have a lot of work to do. I mean, if we do a blood test that identifies some cell-free DNA, that identifies someone with a very early stage ovarian cancer, it'd be hard to see that if you actually go in and try to do surgery. So you're still going to be faced with taking out both ovaries, because if you're detecting microscopic disease, there's going to be no way to know which ovary is effective and all of that. And I think there's a lot of work yet to be done. And even in women who have ovarian cancer, the data is developing, but it's not there yet for whether there is DNA of ovarian cancer in the bloodstream, as there is in some of the other types of cancers that are more spread in a more through the bloodstream, like lung cancer, breast cancer, that sort of thing.
Since I have you on, let me jump into some of the questions that have already been coming in through the chat room. There's obviously a significant interest in PARP inhibitors, and should PARP inhibitors be available for everybody or select group of patients? I think majority of us today really give it a lot of consideration to use them following chemotherapy with the intent of maintenance therapy. what do you tell your patients after completing their chemo? And do you advise certain one of them to get that, or do you have a way to differentiate who benefits and who doesn't benefit from this?
Yeah, I mean, this is challenging. First we find something that works, and then we try to use it in the best way possible, and minimize toxicity of ineffective treatments. One of the most important things we should be doing for every one of our patients with advanced stage cancer, because we're really not using these in early stage disease. They're new. They do have toxicity and risk. So, in early stage, hopefully we're curing some of those patients before they need a PARP inhibitor. But, we now have genetic and molecular testing that can help us identify those patients who are likely to have the greatest benefit. And really going forward, the way I see ovarian cancer going, it is not one disease. So many of these cancers are many, many diseases, and we're just starting to differentiate a group of women that we identify as homologous recombination deficient and proficient. And it's that HRD group, women who have BRCA mutations, RAD mutations, and a number of others that get the most benefit from PARP inhibitors. And for those patients, I really strongly recommend, and we find that out by doing germline testing to look for inherited mutations, as well as tumor testing. And tumor testing picks up a lot of women that are going to have benefit from PARP inhibitors that don't have an inherited mutation. For the other group, it's more challenging because there are some data that demonstrate potential benefit if you use a PARP inhibitor after initial chemotherapy, even if there is not that HRD finding. It's a much less of a benefit. And so, I think I have a discussion with patients. My suspicion is that we just need a better test to further refine. We may be missing some of those patients that are actually HRD that look like HRP, and those are the ones that are benefiting from these PARP inhibitors in the studies, because they're just mislabeled as being HRP. So we need to continue. Every time we make an advance, we have to further refine it. But I think it's fair to offer PARP inhibitors to all women, but you really, in that HRP population where the benefit may be less, we really have to have a discussion about side effects, cost, and there's the potential they're taking on a treatment that's really not going to benefit them.
When you typically start somebody on a PARP inhibitor, what kind of generic side effects, or what we call toxicity, do you feel it's necessary to inform them about? Because I think people, now that we're using these more often, I think we see a range of side effects, some that were not publicized as much as others in the early phases. So I'm just curious, as what does your conversation look like with the patient?
Yeah, I mean, everyone is individual in how they experience the side effects of any of the treatments we use. But I always warn patients the first month or two are really the hardest for most people. You have some people that really, do amazingly well. And I say, are you sure you're not having any side effects? But, I think the GI side effects are very difficult for women. They're already somewhat fatigued, often from coming through their course of chemotherapy treatment. And, everyone wants the pill for cancer, but a lot of these oral treatments can cause nausea, bloating, poor appetite, food can taste funny. I mean, some of these are true with chemo as well. But we're talking about a treatment you take every day, day in and day out. You don't get a break from it. The other thing, so the GI side effects, and I really urge women to be very aggressive using their rescue medications. A lot of those side effects actually diminish. And when I have someone who's been on it for about a month, they'll tell me, oh, I can start to see that some of this is diminishing. I'm turning the corner. But the other thing is the blood count issues, and those can be a problem both early on and persist. You know, sometimes women will need periodic blood transfusions. You may have to modify the dose to mitigate problems with platelets or white blood cell count. And that has to be followed pretty closely for the first month until you have a sense for how the bone marrow is tolerating this. Those are probably the two things I spend the most time talking about, but there are a number of other side effects. You're absolutely right that can occur. I just tend to focus on the more common ones. There are rare, serious complications that can happen, but we tell our patients to just call us if they're feeling really, really ill.
Dr. Stickles, I'm curious as what does the conversation for you look like as you advise your patients, and what kind of common side effects do you run into and how do you manage it?
So what I always remind patients, just like Dr. Martin mentioned, just because it's a pill doesn't mean it's free of side effects. I warn them about the ones they can't see, but I can, such as their blood counts, particularly their platelet counts and red blood cell counts going low. Those I usually tell them that they will resolve by about 3 months. It's what most of the studies have very consistently shown, is that most of the abnormalities in blood counts will resolve by 3 months. So that's what they can't see, but I can see. The other laboratory values that sometimes raise alarm for the patient's other physicians is the rise in the creatinine level. And that's a common test that doctors check to get a rough estimate of how well your kidneys are functioning. But PARP inhibitors reduce the body's ability to excrete creatinine out of the body. So it will make it artificially look like someone's kidneys are not functioning very well, when in reality, they're functioning just fine. So I warn the patients that, if their other doctor happens to look at their blood count and their metabolic panel that I order, not to necessarily freak out about the increased creatinine. In terms of what the patients themselves experience, the patients that are mine on this call will tell you, I call it the wall of fatigue. You feel like you're just so tired, you don't want to leave the house, you don't want to do anything. And I warn patients that sometimes it will require a 1-week treatment break. It's not the end of the world. That's how the clinical trials have handled these side effects, is to give patients a treatment break and to resume at usually the dose they were on, and the vast majority of them will get over it. But just to mentally prepare, that first month and a half will be kind of rough. And I've had patients who celebrate finishing chemo by taking a trip abroad, and I tell them to not book their tickets until they've been on their PARP inhibitors for at least a month and a half to make sure that they're going to be able to enjoy their trip.
Yeah, actually, I do hear this quite a bit from patients that with the chemotherapy, they knew exactly when to expect their side effects after a few cycles. They was very predictable. And this idea of taking a pill every day seems like some of these side effects linger. They don't go away. They're there every day. And this is a frustration for oncologists as we want to move to some of these more convenient oral therapies, and yet we face these challenges with the patients. I'm very much like you. I give patients a lot of breaks if they want to go on a trip of their they've been working on and dreaming on. I usually say stop the medication, go enjoy yourself for a week, 10 days, and come back and resume. And typically, as you said in the trials, that's how it was designed. I also want to tell our audience that when we talk about ovarian cancer, and I have to remind myself and remind our patients that sometimes there's up to about 50 different diseases that we could talk about. You can really parse it into these different cell types. And Dr. Martin alluded to the fact that all cancers are not treated the same. And we do try to really individualize, not just based on molecular level, but also histologic level. And we're learning that, a clear cell carcinoma of ovary may have a totally different profile than a high-grade serous carcinoma, and certainly very different than low-grade carcinoma. I am cognizant of the fact that we have young patients with low-grade ovarian cancer. So these are low-grade serous carcinomas. And I'm just curious as what's your approach to these patients, Dr. Stickles? How do you, once you know that's what it is, do you advise chemotherapy after surgery, and what other alternative treatments do you choose for them? I suspect you don't give them PARP inhibitors.
Yeah, you'll be correct. Yes, I don't offer them PARP inhibitors just because they're biologically very distinct from high-grade serous carcinomas. The way I counsel the patients is that these diseases don't respond to the traditional chemo we give to regular ovarian cancer. So therefore, I really, as a surgeon, you always want to do the most beneficial surgery for your patients. And we're still doing a decent amount of upfront debulking, even for high-grade serous carcinomas. But for the low-grade serous carcinomas that once you make a diagnosis and you know that they have some disease in the abdomen, I really try my best to clear it out surgically, just because I know they're not going to be responding to chemotherapy at the same rate as the high-grade serous carcinomas. Having said that, if you look at most of the studies that were done and designed, there's very few specifically for low-grade serous carcinoma. There's one trial that's ongoing now comparing chemotherapy plus letrozole to letrozole by itself. I know there have been a question from Sharon about letrozole endocrine therapies. I think that specifically applies to low-grade serous carcinomas. There's some retrospect studies. So studies are not designed, saying half the patients get this, half the patient get that. That's go for 5 years and see what happens. So retrospective studies are designed looking at, we've done this in the past with these patients with these diseases. What happened to them? Let's look at their outcomes compared to these other patients that somebody else had treated with this other disease. So looking backwards, there's some evidence that medications like letrozole and aromatase inhibitors can be helpful, particularly after chemotherapy or surgery as maintenance treatment. So nowadays, now that we have the clinical trial, I'm a huge proponent of clinical trials, particularly for very rare diseases, because at worst, the patient's getting standard of care treatment. At best, they may be receiving something that ends up being better than standard of care. So while yes, chemotherapy I offer it with an asterisk, knowing that, we probably are not going to get the response you would see with high-grade serous carcinoma, but because that's what's been tried in the past, that's what's been studied most often, I am still offering it, but with that caveat.
Yeah, so the trial you're talking about is actually fascinating in that patients after surgery can be randomly assigned to receive chemotherapy versus skip the chemotherapy altogether and go directly to hormone therapy. And I do have a sincere belief, even though I don't practice the hormone therapy right today, that may be the way of future for this disease. I have some optimism and maybe a prediction that that's what we're going to learn from this trial. So, Dr. Martin, what can you tell us about this disease and what kind of developments have occurred in this area, and what are the exciting trends that you see? I know you were involved in some of those MEK inhibitor trials and so forth. So maybe just comment about that.
Yeah, so, targeted therapies, there are a class of drugs that target pathways that have been discovered to be more active in cancer cells than their normal cell counterparts. One thing I do a lot of molecular testing. Some doctors use Foundation or Caris. Some institutions have their own molecular testing. I think it's particularly important to be doing this in the low-grade cancers. A good portion of them have BRAF mutations, and that's a situation where there's very little data, but there are drugs approved to treat melanoma patients who have BRAF mutations, and we can often get a compassionate use exception to offer those to our patients. The MEK inhibitors have similarly shown activity. That's just another pathway within the cell that drives its growth and activity. And actually, they are seeing some women with low-grade cancers do have tumor BRCA mutations. And I think in that setting, it's reasonable to try a PARP inhibitor. No data yet, but I think when you do a molecular test and you have a finding of a mutation in a rare disease like this, because this really does qualify as a rare disease, you can make an argument and often get drugs that might be approved for that mutation in a different type of cancer and offer them to your patient. Because as Dr. Stickles said, we will try chemotherapy and some people do get benefit, but it's not the kind of benefit we see in our higher grade cancers. Women with low grade cancers typically still have a much better outcome. But, again, in the interest of sparing toxicities of treatments that have less effectiveness, looking for some of these other options that may work better in the setting of certain mutations is the way to go. We haven't always done these low-grade patients. Treating them like high-grade cancers doesn't really serve them best sometimes.
I'm curious, you mentioned molecular testing, and the one class of ovarian cancers that seem to present a challenging situation is actually clear cell carcinomas. They have a unique space of their own, and some of us, used to think that maybe they're even in the same class as the kidney cancer category, the renal cell carcinomas. I'm curious as how do you approach them when I'm sure you have a number of patients that come to you with recurrence of these clear cells after somebody has tried to obviously surgically resect them and they recur. Have you seen successes and new opportunities?
Yeah, that's a great question. And I know you published on this early in your career before we had some of these exciting molecular tools. I still give chemotherapy. I have had women with clear cell cancers really respond well to chemotherapy. And we don't really have a good test to determine who's going to benefit from chemotherapy or not. There is data from something called the Tissue Genome Atlas survey that would suggest that women with or clear cell ovarian cancers are more likely to have a high number of mutations in their tumors that make them susceptible to immune therapy. I actually have not seen that in my patients, and maybe it's rare, and maybe I'm not seeing the ones that are benefiting from those agents.
I have not either.
I mean, it is rare, but I think that there are some immune regimens that are showing promise, not just in clear cell cancers, but actually in, we haven't had the same success in immune therapy in ovarian cancer that we've seen in melanoma and lung cancer and some of the other cancers. But there are some angioimmunoregimens and immunoregimens where you're combining treatments that I think show promise. But it's very hard to do these trials in these rare cancers because it's hard to find patients who meet all the safety criteria and are willing to travel to seek out trials. And there just aren't as many trials for a rare cancer as a common cancer because it takes such a long time to get the answer you're looking for.
We do know that these clear cell cancers occur more in patients who've had endometriosis, and also sometimes endometriosis patients can have endometrioid adenocarcinoma as well. Supposedly, based on read of some of the literature, you could have BRCA mutation in those patients as well. But so certainly I think testing is indicated, just like you both have mentioned. There was a question in the chat, and I want to ask Dr. Stickles for early stage clear cell carcinoma, whether it's a 1A, 1B, 1C. I know the guidelines say give chemotherapy. Knowing how ineffective our chemotherapy is in this disease, sometimes if you have a stage 2 or 3 and 4, have no better choice. You have to give them the chemotherapy. Are you selective about who you give chemotherapy, or do you just follow the guidelines and you just give them the 3 to 6 cycles?
Yeah, so what a great question. Thank you for posing that. There's some recent data suggests clear cell carcinomas of the ovaries are not even by themselves the same disease. That early stage clear cell carcinomas behave very differently than late stage clear cell carcinomas. Traditionally, we always thought that clear cell carcinomas are bad prognosis. They are associated with high risk of getting blood clots and devastating blood clots in many, many parts of the body. But I think really biologically speaking, your stage 1A, 1B, 1C, I've never seen a 1B clear cell carcinoma, but 1Cs are going to be very different behavior wise, and literature supports that their prognosis is quite good. Now, having said that, it's a difficult counseling conversation with the patient because yes, we think that they're probably going to do pretty well, but pretty well means that there's still maybe an up to 10% chance of recurrence. And a recurrent clear cell carcinoma is still a very devastating disease. And these are young women with very long life expectancies otherwise. And the vast majority will tolerate carboplatin and paclitaxel fairly well for even up to 6 cycles. So it really is a very individualized conversation. I present the data, I guide to the extent that I think I should. And I leave it to the patient in terms of what are her priorities for that particular situation. If her priorities, I'm going to do whatever I can to try to beat this as much as I can, then, we go for 3, maybe up to 6 cycles of chemotherapy. Their priority is, I really want to be as evidence-based as possible, really maximize my risk benefit, then maybe we choose to observe. Or, you can say, let's try chemotherapy, see how you handle it. If it's really not agreeable, I mean, it's not agreeable for anybody, but, if you're really finding it very difficult to tolerate, then we can stop, knowing that we may not be doing that much harm by stopping early.
Yeah, I do want to share that in the recent years, as I've evolved and kind of had built some experience, I've diverged from the guidelines. I really think, like what you said is true. These early stage cancers are not the same as the very advanced one. And even though it has the name of clear cell carcinoma, on a selected individualized basis, I've actually avoided chemotherapy with no worse outcome than, let's say, my partner who gives it to everybody. So it is an area where, one of the things as an oncologist I've come to appreciate is that, it's really nice to be able to spare somebody intelligently from the side effects and complications of these treatments, and so maybe I'm in my phase of career where I'm trying to decide when not to treat as opposed to when to treat. So, Lainey, do you have any comments about this and how you approach it?
Yeah, I mean, I think I really would echo everything Dr. Stickel said. I do really talk about the lack of data in this setting, similar to the low-grade serous cancers for the adjuvant setting. We really base everything on the more common ovaries. High-grade serous ovary cancer is our most common subtype, and that's where we've done our studies. Those are the patients that have gone on the trials, and we then take that information and apply it to all of these other cancers. But I do offer chemotherapy. I'm not as, I've had some patients with advanced disease do exquisitely well and get really great responses to chemotherapy. So I think that though the point of these early stage cancers, I don't really like to give as many cycles when I do give chemo also to mitigate the toxicity. And, as women are living longer, long-term effects are more meaningful.
An area that you can't avoid as an oncologist today is immunotherapy. And I was just citing some of our successes earlier today to one of my nurse practitioners. I'm curious as how Dr. Martin feels the immunotherapy fits in the space of ovarian cancer. And I know I'm asking you to, summarize it, but what do you think? Are you excited about that tool, or do you find that maybe this is not the right disease for it?
No, I think that we are going to find an immune regimen. It's not going to be single agent PD-1 inhibitors that you see on TV advertised for lung cancer with them pushing grandchildren on swings. We have studied those drugs. Those drugs are some of the, in fact, the people that developed these, what we call checkpoint inhibitors, earned a Nobel Prize for that work. And it has unleashed so much learning about how the immune system interacts with cancer. We will have benefit from that in ovarian cancer. We have studied it in the upfront setting in combination with chemotherapy. That's a path that has shown some success in other cancers and has not been so successful in ovarian cancer. There are 2 studies outstanding that are doing it slightly differently, and we will wait for those results. I think, in the recurrence setting, I'm most excited about these combinations of checkpoint inhibitors with anti-angiogenic drugs. We're seeing some impressive results. There was a regimen approved for endometrial cancer that's showing impressive results. It's very toxic, and we need to fix that. There's a recent publication of an institution that did a study of another immune combination with a drug called Avastin that we use in ovary cancer, and another drug. We have to try to figure out how the immune system can be trained to recognize ovary cancer cells as being abnormal. And I don't know if the use of an anti-angiogenic drug in combination with an immune drug creates a more immunopermissive environment where the tumor can no longer shut down that immune response, or what it is that, but I do think that in the next few years, will we be using combination therapy? They're very toxic right now, and we're working on managing the toxicity. I don't know yet. It's too soon to say whether we will get the really cures that we think we've gotten in some of the other diseases, but we are going to work toward that. And I think we're going to focus, there are women now, the HRD situation, I think we've really changed the natural history of the disease in that group. And the focus in that group is going to be what happens when your disease becomes resistant to PARP inhibitors. What can we do next? And there are already studies looking into that. And then in this other group that really doesn't see the same benefit from PARP inhibitors, we're going to have to study these more innovative immunoangio combinations or things like CAR T or other types of immune therapy.
Can I also ask you if you have a woman who is, let's say taking either immune therapy or PARP inhibitor, and that there was a question whether there is a limit on the time duration of therapy, assuming they're tolerating it okay, with reasonable side effects. What's your practice? And let's say the patient really has benefited and their cancer has either shrunk or completely responded. We do have a few of those, I'm sure, in your practice, my practice, Dr. Stickles. What do you do? Do you keep going beyond 2 years, or do you think we should revisit that issue? I know there is really no right or wrong answer, or maybe you feel otherwise.
Yeah, I mean, there isn't a true limit in recurrent disease. In the upfront setting, we should stop because some of those patients will have no active disease for years, and we don't want to continue to expose them to the toxicity of a PARP inhibitor. With immunotherapy, there's not good data for proceeding beyond 2 years. So if you have someone that is getting an immune therapy and they're reaching that 2-year time point and they've had a complete remission and that's been present for a while, I think it's reasonable to stop. There are some studies in lung cancer and melanoma that in people who have achieved a remission, that often lasts beyond the time that you stop the immunotherapy. And in the setting of recurrence, in the patients who do recur, you do see, again, nothing's 100%, but you see responses again when you restart that type of treatment. So I think we don't know yet what the long-term effects of these checkpoint inhibitors that are activating, what are we really doing to people's immune systems? So far, the early patients with melanoma are still doing very well. We're not hearing anything concerning. I think really long durations of PARP treatments, we are seeing some secondary cancers. It's rare. We don't know if it's from chemo or from the PARP inhibitors, but I think when you have a patient in remission, as women are living longer, do we really want to continue to expose them to the side effects of some of these drugs? And there, as you said, there's no right answer, but.
Okay. Dr. Stickles, one of the questions that came up is something very practical that you all, think about every day, and it's about CT scans and CA-125s. And I know there is a push by our organizations to do a little less testing. I'm just curious as what do you think is a reasonable middle solution for this? How often do you end up getting these tests on your patients as you have your patients in surveillance?
Yeah, so I had inherited a decent chunk of patients from my partner who retired about 3 years ago. And I have discovered that his long-term survivors, they have been checking it yearly for 10 plus years. It's a difficult conversation to tell the patient to stop. It's always easier to never initiate something than to stop something that's already in motion. So I present the data very clearly. There are many studies out there that have shown that checking CA-125, checking CT scans in people who otherwise feel very well, you are going to find quote unquote recurrences early. In that you're going to find a rise in the CA-125, and often you will see a preceding effect of the rise of CA-125 before you will detect anything that's on CT scan that looks like a recurrence of the cancer. And sometimes these very small recurrences will be completely asymptomatic. Now, studies have shown that whether you detect the recurrence earlier because you caught it with a blood test or a CT scan, and you put the patient on chemo right then and there, versus you caught the recurrence because the patient had pain, bloating, some kind of weird abdominal symptoms that prompted you to get a blood test and a CT scan. Ultimately the patient lived the same amount of time. The patient that got chemo earlier isn't going to live any longer. So ultimately what I tell patients is that you can find it earlier, but you're going to spend more time on chemo with lesser quality of life because you were asymptomatic when this got caught by a CAT scan. You would not have known that you had the cancer back. Now you're on chemo and you're on chemo longer. You're really not going to live any longer as a result of that early detection. So I generally try to steer patients into, if you're not going to do anything with the results, why would you order a test? I do get resistance, particularly from some patients that just really want to know, and they have a community of support, whether it's on the internet or other support groups. And there's a wide range of practices across the country. So, their girlfriend in Florida may have their oncologist check their CA-125 and CAT scan every 3 to 6 months. And it's a difficult conversation, right? Because why is somebody else getting something I'm not getting? But I try to present it in a way that if I'm going to intervene for you, I want that intervention to be helpful to achieve your goal of living better and living longer. If neither CA-125 nor CT scan routinely is going to help you achieve that goal, I don't recommend it.
One of the questions that was in the chat was about increase in CA-125, and it's interesting. Over the years, I've seen increased CA-125 sometimes be associated with something that's completely irrelevant to their ovarian cancer. Obviously, if you get one as an doctor who's treating this patient, I have to investigate it. I have to see why is it elevated. But I do want to say that anything that irritates the abdominal cavity, whether it's inflamed hernia or diverticulitis or appendix, some fluid in the lung from pneumonia, cirrhosis of the liver, these are some of the things where I've come across where you see an elevated CA-125. But obviously the primary concern is that this is recurrent ovarian cancer. I want to be respectful of the time that we have, and I want to turn it back to Nina as well as our wonderful audience. And I've tried to incorporate the questions into the topics that I wanted to cover, but I want to take maybe 10 minutes to see whether, we could have a dialogue and questions and really get to some of the questions. So Nina, can I turn it back to you?
Sure. And I will say, Dr. Shaheen, you were spot on, because we could spend hours, I think, discussing all the questions that I've seen come through the chat and also those that were included during registration. So, we may not be able to get to everyone's, but I do have a list of them, and I can certainly check in with Dr. Shaheen for further information on some of those questions that we've seen. Dr. Shaheen, you had mentioned possibly discussing the vaccine, COVID vaccine, and the booster. If you feel that that's appropriate to discuss, I think that I've seen a couple questions come through about that.
I think, my knowledge and recommendation with respect to that is evolving. I have encouraged all of my patients to receive COVID-19 vaccination as the vaccine became available. But I'm also cognizant of the fact that some of our patients who are on active treatment may not mount enough immune response. And I've actually encountered a few patients who, despite having been vaccinated, don't actually have an antibody. And for sure, those patients were pushing to get at least a booster and rechecking an antibody level. I have unfortunately lost two patients, one young in her 30s and one in her 60s, to COVID-19 after having controlled their cancer. And it's very frustrating because neither of them were willing to take the vaccine. I'm curious as whether Dr. Stickles and Martin have any other differing opinion on this topic.
So I have encouraged all of my patients to get vaccinated as well, and along with all their regular household contacts. And it's a difficult conversation, particularly for someone who may be a little bit resistant at baseline or a lot resistant at baseline. The thing is, it is not a magic blanketing protection, right? So that's true for for people like us that are not immunocompromised as well. We do know that from the earlier studies out of Europe and out of China, that people who are on chemotherapy will get sicker and die at a higher rate compared to patients who are not immunocompromised. So whatever immune response they may be mounting, though, it may not be the same as an otherwise healthy person. I think will, every little layer of protection helps, just like that extra mask that you're going to put on, or, like staying a little extra distance away. Everything helps. I am recommending boosters to my patients. It's a little harder for those that have completed their therapy, say 6 months or a year ago. We're not asking, should I get the booster sooner rather than later? I think that's the more difficult question to answer, because I'm not sure the scientific data is out there to answer that particular question. But I think for patients on active treatment, the data is fairly clear. They don't mount as high of an immune response, and a booster shot does help. So I do encourage the mRNA vaccines, but just because we know more about them, and then the booster shot after 28 days from the second dose.
Yeah, I would absolutely agree with that. And even for my patients who aren't on active treatment now, if they were at the time of their initial vaccination, I encourage them to get the booster. I don't think you have to demonstrate antibodies to get benefit. And relying on herd immunity is very risky, because even fully people who are not immunosuppressed, who are fully vaccinated, can get this infection and be asymptomatic and shed it. So herd immunity somewhat relies on the virus not being around at all, and that's not the case with this. So I am suggesting all of my patients to get the vaccine. And there is a concern with people on chemotherapy that their immune system won't mount as vigorous a response. But as Dr. Stickles said, any layer of protection, some protection is better than no protection. And with our chemo regimens, there are periods during the cycle where the immune reconstitution is close to 100%. So the idea of immunocompromise for women with ovarian cancer on treatment, it's not an all or none thing like it might be with someone with leukemia whose bone marrow is already abnormal. And so, trying to time it is tricky. We just don't know enough about it, but I wouldn't say that it is not going to be helpful. And I suspect that there will be additional boosters in the future, although, it's kind of turning into the flu where we get a flu vaccine every year, right?
Correct.
So I encourage all my patients also to get flu vaccines.
Nina, other questions?
Let's see here.
I know there was a question about what's an ATR inhibitor. That must be somebody who is looking for some clinical trials. So at the moment, I don't think there is any commercially available ATR inhibitors, but I think Dr. Martin probably can teach us a little bit. But there's essentially a class of medications called ataxia telangiectasia, and I think it's a RAD something inhibitor.
RAD3 related,
So
inhibitor.
the goal is, I guess, if we could use that in combination with PARP inhibitor, maybe we can overcome the resistance. Any comments on your part, Lainey?
Yeah, absolutely. I was mentioning that for women who have developed a resistance to PARP inhibitors, we are already studying how that resistance occurs, something that we really couldn't study for chemo, right? We don't understand chemo resistance. And there are a variety of tyrosine kinase inhibitors that are being studied in combination with PARP inhibitors. Depending on how the resistance developed, adding an ATR inhibitor can overcome that resistance. We see that in the lab. There is some preliminary data from a clinical trial we have here at Penn that was presented at ASCO that last year, or this year actually, that is showing some benefit. I think there is also the question, when you find something that adds benefit, ultimately you want to see, can you prevent resistance? Not just can you react to it, but can you prevent? That will be harder to predict because there are a variety of different BRCA mutations and HRD type mutations that we're going to have to learn about and maybe have more precise treatment assignments in the future for those different mutations.
That's really exciting. I know that there's been some disappointments in some areas, but I feel like that's going to be one of our next frontiers. Nina, other items? I know there's some questions in the chat about breast and ovarian cancer, and we know about the BRCA patients, but I think the audience is looking at beyond BRCA patients. Should our ovarian cancer patients also be alarmed about breast cancer? What's their individual breast cancer risk? Is it higher? Is it lower? What do you tell your patients, Dr. Stickles?
So based on epidemiologic data, in the absence of a BRCA mutation, there may be a small rise in the other cancer if a patient is diagnosed with one of them. Now, does not rise to the level where you should be talking about prophylactic mastectomy. The other interesting intersect between breast cancer and what Dr. Shaheen and I do is that we sometimes will see patients that are premenopausal that have estrogen receptor positive breast cancer who are deemed to need 5 to 10 years of anti-estrogen therapy, whether that be in the form of tamoxifen or an aromatase inhibitor. I'm sure Dr. Martin can speak to much better than I can about, the rationale between one versus the other. But, that's the other situation where I'll see a breast cancer patient that comes to me saying that, oh, I was told to have my ovaries out. It's almost kind of like two birds, one stone, if you will. They're getting benefit in terms of maintenance treatment for their breast cancer, reducing the chance of that coming back. But also, if there is indeed a small rise in their personal risk for ovarian cancer, we are preventing that by taking out the ovaries. But I let the medical oncologist guide me on when it would be appropriate to offer that.
There were some questions about what do we mean by stage, as early stage or advanced stage. And I do want to clarify that we as the community of GYN oncologists really view the stage 1 disease very different than stages 2, 3, and 4. In the US, it's been typically the case where advanced ovarian cancer patients are placed on clinical trials, and those patients are typically stage 3 and 4. Interestingly, in Europe, I believe stage 2, 3, and 4 are kind of considered almost together and the same. So when we talk about early stage, we really are more talking about the stage 1 disease to distinguish that. And so I hope that answers some of the question that's there. There was a specific question about, are there any roles and effectiveness for cannabinoids for clear cell, or peritoneal cancer? I actually am a certifier for medical marijuana in the state of Pennsylvania, and I wanted to ask maybe Dr. Martin to comment. Do you have any data on cannabinoids being effective in treatment of cancer, or any cancer, or even ovarian cancer?
Yeah, I have not seen good data on control of cancer. The best quality of data I've seen, and it isn't really even sort of New England Journal level, is on some of the side effect management. And I certainly have had some patients who feel that they get benefit from cannabinoids in controlling symptoms that they have from a variety of our treatments. There is some intriguing preclinical data, I think, on whether there are mechanisms that might interfere with cancer cell growth. But, we see that so much with so many things that then get tested in people, and the story is always much more complicated in people. And it's hard with researching cannabinoids because there are so many different varietals of the plant that have varying levels of THC and cannabinoids, and how do you know that you're studying the same thing? It's not really standardized. So I would defer to you beyond that. Right now, I just don't think it's ready for prime time.
I'm right where you are. I think we can manage the symptoms of disease as well as symptoms of our treatments with cannabinoids, but I never have come across really convincing literature that cannabinoids have any effectiveness in by themselves treating the cancer. There was a question about what's the prevalence of lymphedema after ovarian cancer treatment, and Dr. Stickles, is that something you want to tackle?
Yeah, so this kind of speaks to how often do we remove lymph nodes in ovarian cancer? And of course, people can develop lymphedema independent of having lymph nodes removed. But generally speaking, in terms of doing a lymph node dissection on patients with ovarian cancer, for the advanced stages, the data is fairly clear that taking out normal looking lymph nodes as part, quote unquote, staging when you have evidence metastasis elsewhere isn't really helpful in terms of cancer outcome. But it does increase the risk of lymphedema. And the data suggests, after a full lymph node dissection, it's somewhere between 15 to maybe about 30% is what I've seen reported. So we don't do a lot of lymph node dissection for ovarian cancer. We do for other cancers, but For ovarian cancer, it's particularly the most what we see are these advanced stages where you're really just trying to clear all the visible tumor. If a lymph node looks normal, you're going to leave it behind. So I'm not subjecting patients to an extensive lymph node dissection that would subject them to that risk. Now, there are ovarian cancers that will spread lymphatically, so you would need to remove those lymph nodes, and or it recurs in the lymph nodes and it's blocking the lymphatic drainage, which then subsequently leads to lymphedema. So just from treatment alone, I would say we don't see too much lymphedema from surgery, just because we're not doing a lot of full lymph node dissections for ovarian cancer.
Yeah, so in early stage ovarian cancers, we do a lot of lymph node sampling, trying to find that one person that has the positive lymph node, so to speak. But you're correct. In our advanced cancers, we tend not to remove them, or if we do, we're only removing lymph nodes that seem large or have suspect disease on it. They actually did a trial in Europe looking at this particular topic, and seems like removing more lymph nodes in ovarian cancer didn't seem to help survival or outcomes. So I think clinicians are slowly decreasing the number of lymph nodes that they remove as part of the treatment. But certainly I've seen lymphedema happen even as a result of infiltration of tumor cells with cancer, and then you treat them and they still have some lymphedema. I also want to say lymphedema is a very complex topic because it's not just cancer and removal of the lymph nodes. People who have had lower extremity surgeries like knee replacement or injuries and pins and all kind of things put in, they seem to have an overwhelmingly higher number of an incidence of lymphedema as time progresses. I know we have gone above our dedicated time. I want to be respectful to my colleagues as well as to our audience. Is there anything else we could answer before we close the session, Nina?
I just wanted to ask one other question that came through during registration. Do you find that the age at initial diagnosis seems to be getting younger and younger? And if so, do you attribute this to anything in particular?
I saw that and I tried to incorporate it in a question to Dr. Martin, I think earlier. And my sense is, I don't, when I look at cancer statistics data, I don't see that. If I'm looking at my borderline tumors of the ovary or my germ cell tumors of the ovary, obviously those target a younger population, but not generically speaking about younger age in ovarian cancer. My friends, Dr. Martin, Dr. Stickles, any thoughts on that?
Yeah, I agree that the SEER data, the statistics on ovary cancer have been very stable.
It is an exciting time, I would say. In the last decade or so, we really have had some breakthroughs and some, I think I wrote that as part of the introduction to the session. We've had more approvals for ovarian cancer and recurrent ovarian cancer in the past decade than in any decade preceding this. So I can only imagine that the next decade is going to be brighter and more fruitful than what we have done. So I'm appreciative to the work that Dr. Martin and colleagues like her do in forefront of the trials and where she is. I'm thankful to Dr. Stickles for really battling it every day on the ground with the patients that she takes care of, and I'm honored to have been part of this group and informing our patients here. I hope the session has been hopeful for everybody. I know there's a lot to cover, and depending on the level of your interest, tell us and tell Unite for Her, and spread the word. Hopefully we can be back and we can even discuss more topics.
Yes, thank you all so very much for your time this evening, for joining us, and for sharing your knowledge and experience with the field and the patients that you serve every day. So thank you again very much. In regards to Unite for Her, I mentioned I did want to go over just a couple different things. Unfortunately, I can't spotlight myself, so you still get to look at our lovely panel right now as I speak. I just wanted to put it out there for everyone that our local fundraising event, our 5K, is going to be virtual again this year. So you can put on your walking shoes, your running shoes, whatever you would like, have family and friends join you, but we encourage you and would love for you to participate in it. It's a really fun event. It's a great fundraiser for us. We would be very excited to have you, and you can find more information about that on our website. A couple reminders about the other options that we have available to you as we continually engage the professionals in our field. We have Ask the Experts once a month also on our Facebook Live. We cover hot topics such as COVID vaccine. We had someone on infectious disease with us just yesterday, and those are available. You can view our past Ask the Experts as well. We have a weekly Facebook Live meditation with one of our counselors at 12:15 every Wednesday. It's just a wonderful way to take a break from what you're doing, clear your mind, restore yourself a little bit. That's always available. If you have not already attended a virtual wellness day, I would love to have you attend. I am the MC for those. We discuss how to use your passport, how the different complementary therapies and integrative therapies that we offer could help to mitigate some of the side effects that you might be feeling. We talk about our nutrition program as well. And lastly, for our national participants that are with us today, as a reminder, we have our National Ovarian Conference coming up on September 10th at 1 p.m. Eastern Time. And Dr. Shaheen will be joining us for that as well at the very beginning to say a few words. And we would be honored if you would take the time out to join us for that. It's our first National Ovarian Conference, so we're very excited on our end. Those are just some of the things that are going on for us. As a reminder, if you ladies have any questions at all for anyone at Unite for Her, please always feel free to send me an email. You can call or text me. We're available at any time to help you. And please use our website as a resource. This is being recorded, as you know, and we're going to put that up there in case you'd like to view it at a later time, as are all of our past speaker series as well. So thank you again, Dr. Martin, Dr. Stickles, and Dr. Shaheen, and all of our beautiful women for joining us today.
Thank you to our patients, particularly clinical trial patients. We do this for you. You are our inspiration.
Thank you
so
guys.
much.
Have a great evening.
Thank you.